All right.
All right.
All right. Hello, everyone.
Hi.
Um,
Is it
nice
okay?
meeting you. And I
It's nice.
am I'm privileged to meet you today. I'm actually happy when people are concerned about maternal and child health. I am Henrietta. I'm 30 years and I've been practicing for almost 8 years now. And in Ghana, we have a straight midwifery program that was developed because we used to have a lot of maternal death, and that was the path I took. So I was able to start working. I'm the ward manager, the labor ward manager at Afo Government Hospital. There are lots of maternal health challenges in Ghana, though, and most is actually related to limited access to skilled birth. Okay, so we have just a diploma training for just midwives, and it's just 3 years, and they are trained specifically for midwives. I know out there you have to be a nurse practitioner or an RN before later you can be a midwife. But here it's not like that. You can just go through it straight to be a midwife. Just that you have to go through some of the nursing topics, but you concentrate more on obstetric and gynecology. And when they actually introduce this thing in Africa, it helps a lot because we are populated and we need a lot of people to help with the skill delivery. A lot of people deliver, just that now delivery rates has actually reduced because of people getting to learn women empowerment and all that. But before, people could give birth like 10, 20, 15, and they just do it in the house or they access the traditional birth attendants, okay? So most of the things I do is to manage normal birth, but sometimes you get some of the complicated birth. Throughout my practice, I've delivered about 12 complicated birth. Some are undiagnosed breech birth and shoulder dystocia. Luckily for me, it's just three of them that had an issue with their shoulder when they came out, but the babies, when followed up, were fine, okay? So here, what I do is I'm the ward manager and I'm also the student preceptor. So I help teach and train students from the ward. Okay. So today I am here with just a little slice. So I'm going to share my screen. Okay, so this is a topic that was given to me by your professor, and it's about the reimagining maternal health through mother work and reproductive justice for you, and that's my name there. So this will be our opening quotes. Act as if it was possible to radically transform the world. And it's actually a quote from Angela Davis, okay? So you want to know if we can transform the world, but it starts from different, you can't do it alone, and you can't also do it all. So I always tell people I meet that whenever you meet someone, act as if you are the only one going to change the world. Please, I hope you understand. So we have to explore what it means to radically reimage maternal health, especially for Black mothers and their communities. Even though sometimes people think of racism as just difference in color, I think racism goes beyond that. It's just not about color. Sometimes we see people, and because of how they are looking, because they are of low social economic status, we kind of treat them different. And I consider all of those things as racism. So it's not just about color, it's about treating people equally, not equity. Equity is about giving preferences, but with equality, you treat everyone the same as and when they need it, not because this person is from a rich background or this person kind of looks cute. This person reminds me of my sister in the house. No, you have to treat people as if it was you, because I always say you can always be a patient. And as most of us are women in this maternal, we can always be mothers. And the moment you become a pregnant woman, that is when you experience what they are actually experiencing. Okay. So we go to the next slide, and it's about framing concepts. Okay. So Patricia introduces this concept of mother work, which challenges the idea that caring for families happens only in private spaces. Mother work blends boundaries. Family is connected to community, and several depends on collective work. This lens helps us rethink maternal health beyond hospitals, clinics, into homes, neighbors, and network. Okay. So it's not just about when they come to the hospital. It's about the neighborhood. How are people treating pregnant women in the neighborhood? Fortunately, in our parts of the world, when you're a pregnant woman, you are privileged. If you get on a bus, there is a pregnant woman, even the old will stand up for you. If, let's say, you are in a queue buying food, people actually prioritize them and treat them well. And that's the support they need. Pregnancy takes your whole body, and it's not just about the baby you are taking care of. Because of the hormones released into the body, people kind of get depressed and people look different. They lose their self in pregnancy. So it's just nice to be nice to a pregnant woman. I always say that. When you see a pregnant woman, you smile at them, tell them, okay, you are doing well. I think just in the community, kind of boosts them, makes them feel wanted, and makes them feel like they are being appreciated for actually helping the society and also helping to reproduce. So when we go out there, we should tell everybody, when you see a pregnant woman, be nice to them. Sometimes maybe the way they look, sometimes pregnancy related effects like spitting may make us not want to go close to them. But I think that too isn't the best. It actually makes them sad. And you see, when you are happy, the happy hormones actually helps you to be able to get a lot of things. So let's look at this. This is actually a data for, you see, maternal mortality is measured in 100,000 births, okay? So this is from the US, and white women is 14.5 in 100,000, Hispanic 12.5, and our black women is 50.3. Why? Why hasn't maternal black health improved? Most of the things that happen is they experience racial abuse. And people think as a black woman, you have strength to sustain pain. This means that like black women are dying like 4 times aside white women. And why must it be so? We are all the same. It's the same systems that's die. And these pregnancy related issues that kill the black women can actually kill white women. Pregnancy is for the body. And when you look at the anatomy of the human being, it's the same. So why is this person dying and why is this person not dying? That says that our maternal health care is being biased. When we go out there and we start practicing, we have to know that every human being is a human being, is the same body, and the physiology that goes into the system of the person is the same. The color is just a superficial thing, is the epididymis, which can change at any time. So the fact that someone has a black body does not mean they are not experiencing pain or they should be ignored. As a midwife, the first thing you have to take notice, you are going to work in a place where people are in their lowest. I'm saying that because nobody will want to poo-poo on themselves. Sorry to say that. But when they get to the labor ward, when the baby is coming, sometimes they have to do it on themselves. And in as much as it's embarrassing to them, they can't stand up and clean themselves. They have to still lie there, push this baby out for this life to come out. So they are in their lowest. You've seen it all. So the only thing you have to do is to be alert and be there for them. We clean it every day. Sometimes when they finish, some of them will be shy. They're like, Madam, I'm sorry. I'm like, why are you apologizing? That's my work. And aside that, even if I was on the streets and I did this on myself, and you are not a nurse, you will still clean me up. That is our community in Ghana. People are welcoming, and when you are in trouble, sometimes you have an accident, and because like our ambulance system are not anxious, um, people would like to help, and they will come and cut the car out and bring you out. That's how they are. So whenever you are treating people, treat them as if you were the one. If I am the one on this delivery couch and my baby is not coming, what will I expect from this person delivering me? Will I expect this person to delay in giving me the care? Or will I expect this person to encourage me, give me all the necessary things that I do? So in Ghana, what actually helps us is we are afraid of the emergencies. So we don't allow it to happen. When you are pregnant, we advocate for you to come to the ANC earlier. Then by 13 weeks, we have a scan to get the dating right, and we do a first HB. We check your HB as your blood hemoglobin level. We realize that most of the things that kill women in the intra
Henrietta, can you hear us? Keep it to off of us. Yeah. Okay. Do it that way, maybe it's block out. Okay. Then that's not about.
Sorry, I think I lost.
Yep,
Yeah, so back.
but we can hear you now.
All right, sure. So what we decided to do with this PPH issue was when you come into labor, when you come to register for the antenatal, we check your hemoglobin level. If it is less than 11.5, we start treating it. And it is routine. If you are pregnant, if your HB is low or not, you are going to take folic acid. You are going to take iron supplements, that's the ferrous sulfates. You are going to take a multivitamin. Every pregnant woman in Ghana is on that medication. That is one of the interventions we do. But I know that in the Western world, it's only when it is indicated. But the moment you get pregnant in Ghana, you are going to take those things. Then when you are 16 weeks gestation, compulsory, every woman will have to take an anti-helminths so that if you have any worm infestation, it's going to bring it out. Then from 18 plus 5 to 21 weeks, we do an anomaly scan. which is also a routine check. Then 28 weeks. We are doing it at 28 weeks because we don't want to wait another 6 weeks for this woman to be near term. So 28 weeks to we check your HB. If it is low, we start either we transfuse you, then we start monitoring you, knowing that at least from 28 weeks to like 37 weeks, 40 weeks, this woman will deliver. It's enough time for us to help get her blood at a normal level. So that's the first thing we do. Then it's compulsory in my facility. Every pregnant woman must have a blood donor because labor is something unpredictable. Your HB can be fine, you can be healthy, but the moment you deliver, you start pouring. And when you start pouring, we have to manage you. Then there is no blood. That would be the issue. And we know that we have to replace fluids with fluids and blood with blood. Always know that. Don't say this woman has lost blood, so let's hydrate. No. Always replace fluid with fluid, like water with water and blood with blood. Okay. So every pregnant woman has blood there. And the good thing is, normally when they deliver and they are safe, they didn't lose blood, they will tell you, oh, keep the blood. I have been saved. Another person will come, she might need it. So it helps us to have enough blood in the blood bank so that when somebody comes, needs FFPs or is bleeding, we'll get blood for the person. The only issue is sometimes logistics. You see, if there are blood, its preservation and lightening system, sometimes we get some of them to go bad. But aside that, everything is fine. So before you get to 36 weeks, when you are 36 weeks, then we check your HB again to make sure this woman is fit for pregnancy. And anytime they come in labor too, if at the last time the HB was checked, it's more than 2 weeks, we confirm. And the moment we confirm and it is below 11.5, we get blood ready for you. We don't want to wait because we know our systems are not as yours, where everything is in order. Because when we wait for this woman to go into hypovolemic shock, we are not going to get a ventilator on an ICU to take care of this woman. So this woman will die. So we don't wait for that to happen. And normally, when you come in labor, before every woman delivers, we have our tranexamic acid there, we have our oxytocin, we have our fluids, we have our misoprostol. If you are not asthmatic, we have carbopros there. So the moment you start bleeding, within 15 minutes, all these interventions will be there for you. As soon as baby comes out, we give you 10 units of IM oxytocin through the thigh. We tell you, but we tell before you deliver, we tell you that we are going to give it to you. We don't even wait for your consent. And we will tell you why we are giving it to you. And normally they will say yes. Then you deliver your placenta, and we deliver placenta through control cord traction so that you don't cause the uterus to invert. And after delivering of the placenta, we actively massage the uterus. We massage until there is no blood coming out. But in cases where after delivering of placenta, blood starts coming out, we shout. We don't have call bells or emergency equipment. You just shout, PPH, and everybody will come. Then one takes control, we set up oxygen. You know, I know out there we maybe you set up oxygen, you ask, is my woman still bleeding? Is she still bleeding before you do those interventions? We don't do that. We over care, we over give the drugs. The moment you start bleeding, I wouldn't wait to see if you are still bleeding before I give the next drug. Everything, you take everything at a stand. The moment you start bleeding, one person is, and the moment they come in labor too, we set 2 lines already. So the moment you start bleeding, one person is putting 40 units of oxytocin into the infusion to run. Another person is giving you misoprostol 400 rectally, 200 sublingually. Another person is giving you IM tranexamic acid, and our blood is getting ready. So sometimes within 15 minutes, bleeding will stop. We will check for the other causes. We know the causes of PPH is tone, trauma, tear, and let's say so we take blood samples to see if you don't have any clot. And ours too is not on the labor room that we are coming to check for if let's say you have clotting issues. We will do that before you come. So we know this person doesn't have clotting. So we check if there is a tear, we suture it. And here the midwives are taught how to do cervical suturing. And we always have speculums on the labor ward. So the moment you see her bleed and you are doing those intervention, you pass your speculum, you check if the bleeding is coming from a tear on the cervix, you start suturing before a doctor comes. We are not privileged as outside to wait for a doctor to come and suture a cervical tear. You are going to lose a woman. And sometimes when you lose the woman, it's so sad. This year we lost a woman, and the sad part is the family kept coming to the hospital to thank us because they saw what you did. Imagine you seeing a patient dying, and family coming to console you, the midwife. That means it's deep.
Mhm.
The story about this woman, I went to work a Saturday morning. It was February. I remember the day very well. When I went, they told me I had PPH. So, as small as I am, I went to bring the oxygen cylinder. Ours is not like connected to the walls, like, oh, you have to go and put the big cylinder. I went to put, and you see, when those things happen, you don't even have time to know if you have energy or not. You will get it. Because one mother dying is an issue. The reports you are going to write, um, the questions you have to ask, the audits you are going to go, you don't want to go through that. It's stressful for a pregnant woman to die in Ghana and you are on duty. It's
Mm.
like you literally murdered her. That's how the case. So no midwife or no doctor in Ghana will want a maternal death. When you see someone from Ghana, you can ask them who is a health worker. She thought those things, it's like an issue because they want to know. We have a policy of no woman should die in labor unless
Mm.
it cannot be prevented.
Mm.
So I pulled this thing, we did everything, and thankfully, there was a cervical tear. We did it, and this woman became okay. So, but I think she started bleeding around 8:50, but she poured a lot, and like she poured over 800 mils. So we got the uterus to contract, we set up everything. Then she was on 15 minutes monitoring. Then I think because she poured a lot, even though we did rapid transfusion and everything, her organs started to fail her. No ICU. We called our only referral point in the Ashanti region, Komfanoche. No space in the ICU. Then BP dropping, heart rate increasing, respiratory rate increasing. This woman saying, please take care of my child.
Mm.
So sad.
Mm.
We
I'm
took,
sorry about that.
we
Yeah,
had
that
to
sounds really tough.
come again.
I said, I'm really sorry about that. That sounds really, really tough.
Yes, and afterwards, the family decided to actually come and console us. So you don't want any woman to actually die. Okay. So this is it. Most of the things are out of medical neglect and racism. Sometimes we feel like they are making too much noise. We are all different. Every human being is different, and every woman has their level of pain threshold. You can The fact that you were able to go through labor without an epidural and you cooperated, you behaved, does not mean Miss Lisa should be the same. We are all different. And every labor has its own thing. It's not like menstrual cramps, or it's not like being whipped by a cane. It's different. So when you go on the ward and someone tells you I'm in pain, pain is what the patient says it is, not what you think you see. Don't say you are two people on the ward. See this woman, she's lying there quietly. Are you the only person? See this person lying down. They are cooperating. Why are you shouting? Always know that we are different and our bodies are different. So what the patient says it is what it is. If you take notice of those things, you will not have issues. There was a woman, she used to shout when she was in labor. She would scream and scream and scream. Then one midwife went to talk to her and she was still screaming. Then after some minutes, she kept quiet. They were like, now she's okay. I'm like, no, she's not okay. When we went to this woman, I palpated and she had ruptured.
Oh,
She had ruptured her uterus, yes.
wow.
So even when you are on the ward,
Mm.
and there's this patient who is actually shouting, and you feel like now she's tired, that's why she's quiet. No. The moment they rupture your uterus, they become quiet. And some of the barriers we get to are insurance. That's one of the things that are issues with us here. We have a national insurance system in Ghana, and it's free for pregnant women, but it doesn't actually cover everything, okay? And sometimes there is delay in getting to the hospital. I wish one day you will come and you come and work with us. You realize that some people give birth in their car. They will call you have to rush to the roadside, go and deliver a baby in the car because there was a delay in getting a transport system to the hospital. There is a community close to my hospital. So we told the chief that is what has been happening, and this chief has actually made a policy that any taxi driver, when you see a pregnant woman, she says she's in labor, don't bargain the price. Put her in your car, send her to the hospital. The next day, come to his palace and take your money. And since that man started that, and I think we are having less issues with transport system. And also some of the women too, they have mistrust because of things others have told them. So they delay in coming to the hospital. Okay. All right. So mother work in action. So some of the things that we can do is to get a lot of community midwives. So when we come out and we want to work, don't just say, oh, going to the community, the weather is not favorable. Some people have issues in their house. I know you guys practice a lot of the community midwifery system in your place, okay? So go and visit them. I know a lot of Black women in the States actually resist care because of their communities. They feel like when you come there, the place is not up to standard or their living conditions are not the best and they wouldn't want to welcome you there. Let them know that you are just like them and you are not there to judge. You are there to make sure that she and the life she's carrying are safe. Okay. So don't let there be a disparity between how we look. I'm like, we as health workers, we have to always be so down to earth so that we can be approachable. When we go back to our homes, we can put on our armor and look all glamorous. Sometimes people actually don't want to come to us, maybe because of how glamorously we are looking. They feel like this person is not going to welcome me. So as we go into the community to practice our doctors, nurses, midwives, any health worker, just be accommodating. Welcome everybody. Sometimes they will tell you about their personal stuff because they feel safe with you. And imagine somebody pregnant and the person is afraid of having the child and wants wants to do an illegal abortion, she sees you're a health worker and she comes to confide in you, and you are able to actually talk her out, and she doesn't do anything funny, you've saved her life. Because if this person tries something funny and after doing that, she loses her life, that is a maternal mortality recorded. And our aim is to reduce maternal mortality. So always in the communities everywhere, know that you are there to be as a help, okay? And also with reproductive and birthing justice, okay? We have to have reproductive justice. That is, we have to have a right to have a child, and everyone has that right. Whoever wants to have a child, if they are in their right sense, they have the right to have the child. And also, if somebody doesn't want to have the right, doesn't want to have a child too, I think they have the right not to have a child. So if you're in a state where abortion is prohibited, then go for the family planning methods. And that is also exercising your rights. If, if you are not getting pregnant because you are using family planning, it's also a right. And you have to also, everybody has the right to parents and in safe communities, okay? So let our birthing be equitable, respectful, culturally centered, and it has to be evidence-based. Let's always work with evidence. What does the evidence say? And let's prevent the delays, not because we know that if this woman should go into shock, oh, can send her to the ICU, she'll be fine. Right now, most of the things killing our women is preeclampsia. And that one, we have little or no control over it. What we can do is when you come, we will give you all that we can do. But if the organ starts failing, our system doesn't support it. The ICU that we have, I think the whole Ashanti region, we have just 2 places that has ICU, and the bed capacity is not even up to 10 for these 2 facilities. So if you are getting other people, know that it's not only maternal cases that are going into these places. So let's have respectful care. I was on this project with Professor Jomiku about respectful mother care. If you have the chance, you can go read that. And you realize that this woman said, we, the health workers, are very good. And even sometimes when they go to the traditional birth attendants in the community and there is any issue, they bring them to us. So they trust us. That's why they come to us. So when they come, let's show them, treat them with empathy and kindness. And they will always come to us. If they come to the hospital and they die, and there is this woman in their community who has been delivering people are not dying, where do you think they will end up going? They are going to go to the woman in the community. And the issue is the woman in the community might not be trained or have the necessary knowledge as ours. So let's not push them away by being disrespectful, by neglecting them. We have to show maternal respect because every woman wants to be respected as we want to be respected. And I think when we start doing that, we respect, we don't neglect, they will come. And just with that, they would feel free to tell us when something is wrong. They wouldn't be afraid of us. And that one too will help us not to lose. I always say when I go to the hospital, I don't stay there for 8 hours. So I always tell myself I'm going. I'm not going to get angry at any woman because she's sick and she's called a patient, meaning I need patience. And I'm going to do what I can do because that is just 1/3 of my day. And I'm going to make sure nothing bad happens to anyone because of me. When you always tell yourself this and you go, trust me, you are going to deliver the best. Bad days will happen. It will remind you that, hey, It's just 8 hours. I think you've done 4 hours, so you have just 4 hours to go. So breathe in and be nice. And you are not going to lose your patient, okay? So this is it. This is an exercise for all of us. What would maternal health look like if we, oh, sorry. Can you see it? If we join rest the survivor, where's central? What do you think will happen? It's a question to all of us. Oh,
Can you go back to that one?
yeah. I don't know why this thing is not working. Okay.
There we go.
What do you think will happen? If we look at it with joy, rest, and a survivor were the central part of it, what do you think will happen? If all of us health workers think that, oh, going to work is actually kind of a joy. Let me go make those pregnant women laugh and let them know that they came here to rest. And let me put it at the back of my mind that every person is going to survive. How do you think it will happen? What do you think will happen?
Okay, let's give them a moment to answer that. Does anybody want to jump in?
Yeah.
Mhm.
I think
Introduce yourself.
hello. Thank you for speaking today. My name is Mia Boyd, and I think it would like really reduce the death rate among all individuals if every provider had a mindset like yours and everyone in Ghana,
Yeah.
and also like having like that mindset of this is my patient and I'm doing everything in my will to make sure they are alive, regardless of skin color or social economic standing.
Very good. So let this be ours. When we are going to the world, we should think of it as I'm going to give joy to that pregnant woman who is her hormones are high. I'm going to let her know that, hey, she came here to rest. She should forget about all the stress at home. Here, we are here to be happy and rest. And I take it upon myself that every pregnant woman I see must survive. Maternal mortality will be reduced. We can't say there will be zero because there are some ones, but all preventable maternal death will not happen. Okay, so let's put this at the back of our heads that as I'm going, everyone I'm seeing must survive. Nobody is dying on my shift unless nothing can be done. And I always say, if somebody would die, not in my labor ward, we will do everything we have to do. Maybe when we transfer the person to the theater or to the ICU, the person can die there. So when the person too in the theater says nobody is dying on my theater bed, then everybody is willing to make this person survive and nobody will die. Okay. All right. Okay. So one thing too about helping maternal health is community engagement. Okay. So if we could get community birth centers, I think you don't have an issue with hospitals and birth centers at your end. So here, if we get a lot of birth centers where you don't have to travel, at least every 1 kilometer has a birthing center, not necessarily a midwife, a hospital with a midwife at post, and also there are policies. Talking about policies, I don't know how you do it at your end, but here we have policies for everything. If a patient comes, there is no doctor, patient has eminent eclampsia or preeclampsia. Even a midwife who just completed school and has been newly posted can treat these patients till a doctor comes because the policies are on the wall. So you read it, okay. So if blood pressure is above 150, there is 2 classes in proteinuria, start mark sulfate. Then you are aborting the patient fitting. Okay, you can give metaldopa, 500 milligram. There is an emergency drug, then you give. So before the doctor will get there, at least this patient has what she needs to survive. So you can set those policies too. PPH, do this, do this, do this. All the policies are set out. Right. When the baby comes out, is baby breathing? Within the first minute, if baby is not breathing, the golden minutes, baby has to achieve this. This is what you are supposed to do. So set the policies about everything. you can be advocates for them. Let them be there. They can be posted on the walls at the labor ward. So when there is a case, and here too, we advocate for our patients a lot. Sometimes you see these patients and like, doctor, you have to go and cut this patient. Normally, when they argue, they end up cutting and they're like, please. So we actually advocate them for, and we can talk to the OBGY. OBGY, this plan that you have given, no. This woman has an SFH of 40. She's gravid at 5, and you are telling me to induce with misoprostol. OBGY, please, I'm not doing it. If you want to, this is a multi-gravid woman. If I give this misoprostol to her, she might rupture. So if you won't cancel her for cesarean session, please come and sit down and give your misoprostol and manage her yourself. Sometimes they are like, we are challenging the past. That's the truth. I am afraid. I don't want this woman to die in my hands. So if you still think your plan is there, I have the right to do what, and that we have that in Ghana. You can decide to tell the doctor, this orders you've given me, I think it's not in the best interest, and I'm not going to do it. And nothing will happen to you. And normally when you say it, they will come and review it. And the funny thing is, those who are stubborn will let their house officers come and monitor, and they realize it's not working, and they'll still end up in the theater. So when you go out, be advocates. Advocates for your patients. Tell the doctor, I think per research or per evidence, this and this is not going to help. Sometimes they might not even realize the order they've given, and after saying it, everything is going fine. So let's actually focus on joy, creativity, and survival of our patients. Okay. And collectively, we can strive to achieve the best. Okay. So these are some of the future directions we can actually decide on. Okay, so we can restructure our maternal health networks and also center Black women's voices. You can do researches, ask Black women their experiences in the labor ward. What do they think? What do they think can help improve the system? And you can also bring on institutional partnership to help reduce this thing, because 50% is very high. That means if you are taking two, then the probability is that, and nobody should be afraid to have a child, because it was given to us freely that we should reprocreate and fill the world. So why should we die? Okay. And we can also train care workers to be responsive to these people. They should know that these people are special cases, and it's not a life you are taking care of, two lives, and sometimes three lives. So they should be extra responsive towards pregnant women. And with these future directions, I think it's going to reduce maternal mortality, not just among the less privileged, or for everybody. And childbirth will never, ever be a scary thing for anyone. Okay. So we can do this by storytelling. People have had near-death experiences, can come out, share their stories, and now there is social media. It can go wild, and people will read it and know that, oh, so this is it. And when people are informed, people get to know their rights. People get to know, oh, this is what goes on in the system. When they are pregnant, we teach them this. It will help them. So when they are getting the signs, they will know. In Ghana, the moment you come and you are pregnant, we teach you the danger signs in pregnancy. And we tell you, and here you don't need to book an appointment, just walk in. So if you see this, if you see that your feet is swollen, come. When they come and we check and everything is fine, then we tell them to go. If you see that you are having difficulty in breathing, come. So you teach them all the danger signs so that when they see anything, they can come in. So let's structure a system that pregnant women will have a priority with booking. They don't need to wait until they are booking. Let's say we can even decide to reduce cost of ambulance for pregnant women, so that when something is wrong, they can come, because sometimes you feel like, oh, going to call the ambulance, they're going to bring me a high bill. Let me see, let me wait small. Maybe this thing is actually going to resolve. And all these things is because of the bill. But if there was a system like in Ghana where you are pregnant and you just walk into the hospital, no matter the time and day, and you'll be seen by the doctor, When they even have a minor issue, they will come. Maybe that will be a minor issue, but next time they'll walk in and the issue is major, then you solve it. And when they come to you, shouldn't say, oh, so you're just having nausea and you are coming. No. What if she started vomiting and she had a fluid imbalance? So don't ever brush people's complaints. I'll take every complaint as the patient says, and it's just being nice. Just talk to them and say, oh, don't worry. So in pregnancy, this is what happens. Sometimes there is dilation, and because of that, you kind of feel like vomiting. So when you wake up, do this, do this. And sometimes when you explain the physiology of what is happening to them, they get okay. They go home and they never come back. Sometimes it's just about telling them the physiology of what is happening in their condition, and just that will solve the issue. They wouldn't need to take any drugs or anything. Okay. So poetry is actually not luxury. We can have podcasts, we can have films too. Okay. So call to action. What role will we play as future maternal health workers? Write this question down, reflect on it, and tell yourself that as a future maternal health worker, I'm going to do this. If any woman should sleep, she slept because I did all that I could. She had the best care, but that was how she was meant to leave the world. Not because I delayed, not because I neglected, but because everything that was supposed to be done was done, but she left. Okay. And with this, we can ask ourselves to how can we reshape systems? Okay, we can do that by caring, by advocating for them, and by being nice to them. Okay. All right, so that is the letter I prepared for you today. If there are any questions, contributions, you can let me know. Thank you.
Thank you so much.
You're welcome.
What questions do we have?
No questions? Did I get people emotional?
I have a question.
All right.
Carla has a question. Go ahead.
Hi, my name is Perla. Thank you so much for speaking in class today. I really enjoyed your presentation. I just had a question.
Carla, tell her who you are.
I met you in Ghana. I
Oh,
was with,
really?
yes, I was with Dr. Wright and all the other students. So it's nice seeing you again.
Oh, welcome.
My question is, so while we were in Ghana, I did research on the Ghanaian Midwifery Association, and I know that you guys are responsible for a lot. Like you guys basically run the whole medical system in Ghana, and I was just wondering like how you personally deal with the responsibility put on you guys, the stress that comes from dealing with a lot of patients, even though you do it with a lot of care. How do you manage those difficult emotions in your job?
As I said earlier, how we manage those things is about the brain. The brain is very powerful. When you tell your brain that I do this for just 30 minutes, and in 30 minutes I'm going to be done, the brain will give you the strength to go through it. We go through a lot of pressure, and our salary is not very good, but with job satisfaction, with midwifery, it's results based. The woman comes, she's in labor before maximum 42 hours, she will deliver. If she's not delivering cesarean session, then she goes. So we always look at the end. We know that we are going to get a result. And with the stress, how we deal with it is just psyching yourself. But when you get overwhelmed, sometimes we also cry, we break down. Sometimes you talk to people, share your experiences. We don't have a recognized support groups, but we serve as support groups to ourselves. Sometimes you come to the hospital, you experience something, you talk to your mates, and we all kind of come together, help you out. Yes. So that's what's basically we've been using to manage our stress.
Thank
You're
you.
welcome. Is there any other question or contribution?
I had a question. My name's Mia again. How does like the free maternal health care services work in Ghana? Because I was doing some research and I see that y'all have a program.
Okay, so there is this, we have National Health Insurance Program. So when you sign up on it, um, when you go to the government hospital and some private hospitals is free. So mostly all the hospitals, like the major hospitals that runs in Ghana are owned by the government. It's not private space. So it's the government that employs us. We are all under the government's payroll. So when you sign up, and it's very cheap, it's like 30 cedis. 30 cedis is like almost $3 for the whole year. So every Ghanaian signs up on it. And when you are pregnant, the moment you take a scan and you send it to the health insurance office, you show it to them that you are pregnant. Even if you are not enrolled in the insurance, they use the scan to enroll you for free. So it will take you through your pregnancy till 42 days after you deliver. That is how they did it for the pregnant women. So every pregnant woman, you get it for free. The moment you are confirmed pregnant, they enroll you in the insurance system and that takes care of you. So it was actually instituted by the government. Yeah. So you can
Thank you.
also do that for your pregnant women. The moment you get pregnant, free healthcare. Till 42 days after your delivery or termination of pregnancy.
That would be nice.
Hi, my name is Bruce.
Yeah, yes. Because people are not okay, sure, let's go.
Hi, my name is Bursu. Thank you for speaking with us today. I just wanted to ask about you kind of emphasized about the hospitality and care that maternal health workers in Ghana have for patients, that allow them to see, their patients more than just patients and a person also compared to the US where there's stricter doctor-patient relationships. So do you think so much of that hospitality in Ghana comes from the culture also that pours into caring for patients?
Yeah, I think it's part of the culture. And also, I didn't tell you this. In Ghana, when you deliver someone safely on the road, they will be calling you and thanking you. So, and we are in the community. So, if you go to the hospital, you don't treat someone well, the person will go and tell the whole community. And Ghana community is kind of small. We walk around. So they'll be like, oh, you see that midwife who stays there? When you go to the hospital, don't let her take care of you. She's not nice. So if you don't treat them well too, you are going to have an issue living in the community. So even if you are nice, you'll be compared to be nice. And I think it's also part of the Ghanaian culture where we are hospitable and all that. But also sorry to say that, but if you misbehave to a patient too, they might meet you on the road and harass you. A good thing though, but it has happened to some health workers before, so you'll be cautious on how to treat them. They're nice people, but they can be they can go back to
Yeah. Okay, we're getting some real what we need to change in America.
And in Ghana, every pregnant woman comes to deliver and they'll come with soap, they'll come with powdered soap, Dettol, bleach, and bar soap. After delivery, they'll give it to you. And it's not like bribery. They have actually World Health Organization have come to ban those things. They said no. The fact that you clean them up when they pooped and their blood spilled on you, they also want to pacify you. And they've been giving that to us when they come to deliver. So we pack them together. Then maybe at the end of the year, we share it among the whole hospital staff. I know nobody will tell you this, but I've told you.
Yeah. We didn't know that before. Go ahead, Michelle.
Hi, my name is Michelle, and I was also with the group that came to Ghana. Hello, and I had a quick question about postnatal care. So I know you spoke
Okay.
a lot about like antenatal care and like delivery. But I was wondering for people who have like complicated like birth, like deliveries, what does postnatal care look like?
Okay, it's not just complicated, but we have a routine postnatal care for every woman who delivers or any woman who goes through an abortion. So we have day one, that's first 24 hours. We do all assessments on you. We check your vitals. We check if you are getting support, if you are having any postpartum blues and anything. Then you come for day five. Then we have 2 weeks. Then we have 6 weeks. Then we discharge you. So if you had a complicated birth, your visiting days will be shorter. Let's say we will see you we see you the first, third day, fifth day, seventh day, 2 weeks. But if it's a normal birth, we see you day one, day five, then maybe 2 weeks, then 6 weeks. Okay, so we have postnatal care and also when you deliver, we teach you about the danger signs in postpartum. We let them know that even though you've delivered, you can still get preeclampsia. We tell them about the danger signs in the neonates. Don't if you saw a maternal child health and record book, all the danger signs are pictorial representation at the back of the book. We tell them when you are home and you are experiencing anything, just pick the book and look at the pictures at the back of the book. If you are experiencing any of those things, come to the hospital. So there is a picture of a woman holding the head. There's a picture of a woman having pedal edema. There's somebody vomiting. There is somebody who losing blood and all that. So that's how it's done. We have a routine postnatal check too for them. So when after insurance ends 42 days after delivery, so the insurance takes you through the postnatal period too.
Thank you.
You're welcome.
Do you have any other questions? Comments?
Okay, so if there are no questions, thank you for having me. I will leave you to continue with your class. In future, if you have any question, you can reach out and I'll be glad to help. And I wish you the best in everything you are pursuing. But as you go there, put this at the back of your mind. Every person I touch must survive. Thank you. Bye.
All right, thank you.
You're welcome, Prof.
Thank you.
Bye.